The following audio is part of a certified educational activity titled A Team Approach to Tackling the Complexities in Later Lines of Therapy for Metastatic Colorectal Cancer. Access the entire activity and complete the post-test at www.peerview.com/XWQ. Downloadable slides and practice aids are also available.
Hello, this is Richard Kim from the Moffitt Cancer Center. Welcome to this education activity on colorectal cancer. Joining me in this discussion is GI cancer nurse practitioner Karen Martin from Abington Jefferson Health. Welcome, Karen.
Thank you, Dr. Kim. Glad to be here.
Metastatic colorectal cancer is rarely curable, but numerous options are available which can improve overall survival. Chemotherapy usually forms the backbone of treatment of metastatic colorectal cancer. Most of the patients with colorectal cancers tend to receive multiple lines of therapy. The selection of initial therapy influences the subsequent lines of therapy. Outcomes can be improved with the addition of anti-angiogenic and anti-EGFR agents to chemotherapy. Despite the numbers of available therapies available, better toxicity profile and better efficacy treatment are still needed. There are numbers of factors to consider in selecting initial therapy. First of all, we look at the patient's performance status and their ability to tolerate intensive therapy. Then we look at the molecular profiling. In 2018, every patient with diagnosis of stage 4 colon cancer must have a molecular profiling done. So we look at the RAS status, we look at the BRAF mutation status, and more recently, there's data that if you're MSI high or mismatch repair deficient, you're a candidate for immunotherapy. Therefore, those markers should also be checked as well. Furthermore, now there is some evidence that the sinus of the tumor makes a huge difference. So if you have a left-sided tumor versus a right-sided tumor, it may determine what kind of biologic you may receive. Finally, the balance of efficacy and the safety of any treatment should always be considered before embarking on this journey of chemotherapy. This slide here shows a variety of chemotherapy combination and backbones which are frequently used in metastatic colorectal cancer. There are 4 FDA anti-VEGF drugs available currently at this time: bevacizumab, ramucirumab, aflibercept, and regorafenib. And there are 2 anti-EGFR drugs agents approved by FDA, which are cetuximab and panitumumab. Last but not least, the anti-PD-1 agents, nivolumab and pembrolizumab, has recently been approved in patients who are MSI high or mismatch repair deficient. Here, we see in a bit more detail the variety of chemotherapy and targeted agent combination which are commonly used in metastatic colorectal cancer. As you can see, the RAS mutation and the location of the tumor play a role in selection of therapy. The most commonly used initial therapy in the United States is FOLFOX plus an anti-VEGF drug. However, in patients who are RAS wild type and have left-sided tumor, the EGFR agents are also an option as well. Let's take a minute to discuss the importance of molecular testing in colorectal cancer. The current guideline recommends that all patients should be tested with the following mutation: RAS mutations, which includes the NRAS and the KRAS, the BRAF mutation, as well as status of mismatch repair or MSI high status. Now, I'd like to ask Karen to give us a nurse practitioner perspective on molecular testing in colorectal cancer.
Thank you, Dr. Kim. Let me start by reviewing some of the individuals who play a key role in molecular and genetic testing: nurse practitioners, nurse navigators, pathologists, physicians, genetic counselors, and most importantly, the patient. When I think of molecular testing and genetic testing, I think about them in 3 separate categories. First of all, when a patient is newly diagnosed, just like you said, Dr. Kim, the molecular testing is vital. So getting the NRAS, KRAS, BRAF, and MSI status is important to have. But then there's also genetic testing, where patients, maybe if they were a younger patient or if they had a high family history or if they had a mismatch deficiency, they might be considered for more genetic testing, in which case that's when we use our genetic counselors. This can be very overwhelming and scary for the patients. And finally, we have some more expanded testing now for molecular markers that allow us to find more targeted agents for patients that we might not have known. The problem is that we're not always sure that these molecular testing are going to actually provide us with vital information and may not give us a clear management pathway, and this can lead to further stress for the patient. All of this is important from a nursing perspective because we need to be the people to tell the patients where their expectations should lie. A recent survey of patients regarding molecular testing found that patients want to know about the benefits of testing, how test results impact treatment, implications for family members, whether testing indicates the seriousness of the disease, the purpose of the test. Patients also indicated a preference for information from their nurse or physician.
Thank you, Karen. You raised a number of important concerns for patients, their families, and their clinical team to be aware of. We touched on impact of genetic mutation in treatment selection. Now I'd like to expand on that a bit. Patients with RAS mutations do not respond to anti-EGFR agents. Therefore, those patients should not get those agents. Furthermore, there's actually evidence that if you have the RAS mutations and get the EGFR drug, that the drugs can actually be detrimental to the patient. Next, we know that patient with BRAF V600E mutation tends to have worse prognosis and tends to respond poorly to anti-EGFR agents. However, now there's data that you could combine the anti-EGFR agents with the BRAF inhibitor to overcome the resistance with the BRAF mutations. Last but not least, the checkpoint inhibitors are now effective in patients with MSI high or mismatch repair tumors. Therefore, those must be checked to see who's eligible for immunotherapy. In this session, we have provided you with some insight into the complex treatment landscape of metastatic colorectal cancer and factors in impacting initial treatment selection. Stay with us to learn about the evidence on later lines of therapy, especially during the later stage of the disease. Welcome back. In our last segment, we reviewed some of the therapeutic options available for managing metastatic colorectal cancer and the importance of molecular testing. In this segment, we'll review some of the evidence on the safety and efficacy of later line therapy options. Let's begin with the patient case. We have a patient here who is a 66-year-old man, presents with progressive weight loss and abdominal pain. Patient is found to have left-sided colon tumor. The biopsy is done and is found to have adenocarcinoma. Patient gets a staging CAT scan done, and unfortunately, patient is found to have multiple lesions in the liver. And the patient is now diagnosed with, unfortunately, unresectable metastatic colorectal cancers. As indicated by the NCCN guideline, molecular testing is done, and patient is found to have RAS wild type, BRAF wild type, and microsatellite stable. The patient then gets started on first-line therapy with FOLFOX plus bevacizumab. But after 6-month therapy, unfortunately, patient progresses with a progressive disease in the liver and also has some neuropathy as well. So what are the patient choices now after progressing on FOLFOX plus bevacizumab? In second-line therapy, the optimal sequence of second-line therapy is not fully defined. Depending on what you use first line, you use the different backbone in second line. For example, if the first line chemotherapy you use is irinotecan, you would switch to oxaliplatin in second line. Or if you use oxaliplatin in first line, you would switch to irinotecan in second line. And depending on the biologic you use in the first line, you could either switch the biologic to second line if they're RAS wild type, or prefer to use VEGF beyond progression if indicated. And for tumors with mismatch repair or microsatellite instability, checkpoint inhibitors can be given as well in second-line therapy. This slide illustrates the current treatment landscape of patients with metastatic colorectal cancer. Let's take one scenario at a time. If the patient has a RAS mutation, it is a little bit more straightforward. Patient would get chemo plus anti-VEGF drug. And once it progresses on it, they will switch the backbone to a different type of chemo, and will use VEGF beyond progression. However, if the patient has RAS wild type and a left-sided tumor, it becomes a little bit more complicated. In first-line therapy, now you have an option of using chemo plus anti-VEGF or chemo plus anti-EGFR. And once you progress on it, you could go to a different biologic or continue VEGF beyond progression. And once you progress on that, you're left with two oral oncolytics, which are TAS-102 and Regorafenib. If you have mismatch repair deficiency or MSI high tumor, you have an option of using immunotherapy in second-line setting. Returning to our patient case, the patient received FOLFIRI plus cetuximab. Now 4 months later, he has new lung metastasis. Currently, there are 2 approved oral oncolytic drugs available to patients after failing 2 or more lines of therapy. These agents are trifluridine plus tipiracil, or TAS-102, and Regorafenib. Before we see the data for these agents, I'd like to ask you, Karen, for some reflection on your experience at your institution with these agents.
Thank you, Dr. Kim. We're fortunate enough to have 2 oncolytic agents in the third-line setting. Both have data to support benefit after disease progression on irinotecan, oxaliplatin, 5-FU, anti-VEGF, and anti-EGFR if RAS wild type. The choice of which to use in this setting is often based on a discussion both with the patient and the practitioner. We typically will review the dosing, side effects, and schedule, and also consider the patient's phenotype when selecting which third-line agents we will use first.
Thank you, Karen, for those insights. Before we tackle some practical issues with this drug, I'd like to cover the data that led to their approval. To begin, let me briefly describe the mechanism of action of TAS-102. TAS-102 consists of 2 components. One is the trifluridine, which is a cytotoxic component, but has a very short half-life because it gets degraded by the enzyme called thymine phosphorylase. Tipiracil is an inhibitor of thymine phosphorylase, which prevents the breakdown of trifluridine, thus allowing the trifluridine to have longer half-life. So when you administer the TAS-102, it becomes phosphorylated into the DNA, thus preventing formation of the new cancer cells. RECOURSE, the phase 3 study comparing TAS-102 to placebo, was a pivotal phase 3 study that got TAS-102 approved in the refractory setting. In this study, patients who progressed on standard chemotherapy were eligible for the study. So the patient must have failed 5-fluoropyrimidine, oxaliplatin, irinotecan, bevacizumab, and if they're RAS wild type, they must have received EGFR drug. Then they were randomized to 2-to-1 to TAS-102 versus placebo. The trial was stratified according to the KRAS status, geographic region, and time from first diagnosis of metastasis to stratification. And the patient continued until there was a treatment progression, and the primary endpoint of this trial was an overall survival. This slide here is a Kaplan-Meier curve of overall survival of the RECOURSE study. As one can see, taking the TAS-102, it improved the overall survival from 5.3 months to 7.1 months, with a hazard ratio being 0.68 and p-value being less than 0.001. In terms of the PFS, by taking TAS-102, it improved the progression-free survival from 1.7 months to 2.0 months. As one can see from the Kaplan-Meier curve, at the 2-month period where you get a CAT scan, there's a clear separation of patients who benefit and patients who don't benefit. In terms of the toxicity from the TAS-102, the most common side effects were heme toxicity. From the table here, the most common grade 3 or higher heme toxicity were neutropenia at 38%, leukopenia at 21%, and anemia at 18%. In terms of the non-heme toxicity, most of the grade 3 toxicity were all less than 5%, and most of the AEs, adverse events, were grade 1 and 2. In a subgroup analysis, TAS-102 improved outcomes in both Western and Asian population. As one can see from the slide here, the overall survival and progression-free survival favored the TAS-102 arm, independent of the region you lived in, including USA, Europe, and Japan. Overall survival for older patients, 65 years or older, was similar to the overall study population. This is important because many of our patients are older. The TAS-102 had an overall survival of 7.0 months in older patients compared to 4.6 months in the arm of placebo. Now, upon longer follow-up, the overall survival difference with TAS-102 was still significant. With longer follow-up, overall survival TAS-102 was 7.2 months versus 5.2 months in the placebo arm. And importantly, if you look at the 1-year % survival, it was 27% in TAS-102 and 16% on the placebo arm. The TERRA studies was similar in design to the RECOURSE study, but was enrolled in Asian patients. The results were very similar to RECOURSE study, with median overall survival of 7.8 months for TAS-102 versus 7.1 months with placebo, and a hazard ratio of 0.79. The median PFS was 2 months with TAS-102 versus 1.8 months for placebo, which was statistically significant. TAS-102 is also being examined in combination with checkpoint inhibitors, nivolumab, and an early phase trial of TAS-102, bevacizumab, was recently published in Lancet Oncology. Turning now to the other agent available in this setting is regorafenib. Regorafenib is a TKI that blocks multiple pathways, including VEGF, PDGFR, and FGFR. CORRECT was a pivotal phase 3 study that compared regorafenib versus placebo and got this drug approved. If you look at the schema of the study, the patients who were eligible were patients who were diagnosed with advanced colorectal cancer, who progressed on all the standard chemotherapies, including fluoropyrimidine, oxaliplatin, irinotecan, bevacizumab, and anti-EGFR agents if they're KRAS wild type. And they were randomized to 2-to-1 to regorafenib standard dose at 160 milligrams per day, 3 weeks on, 1 week off, compared to placebo. And the primary endpoint was overall survival, and the secondary endpoint was PFS, progression-free survival, and response rate, and disease control rate. If you look at the clinical outcome of the study, by taking regorafenib, there was an improvement in overall survival and improvement in progression-free survival as well. In terms of the overall survival, it improved from 5 months to 6.4 months, with hazard ratio being 0.77, and the progression-free survival, it improved from 1.7 months to 1.9 months, with a hazard ratio of 0.49. The most common adverse events seen with regorafenib are fatigue, hand-foot skin reaction, and diarrhea. Of note, if you look at the grade 3 toxicity, the hand-foot skin reaction was about 17%, and the hand-foot skin reaction typically occurs within 4 to 6 weeks of starting the treatment. A similar trial was conducted in an Asia patient, was called the CONCUR study. The eligibility criteria was very similar to the CORRECT study. And similar to the CORRECT study, the overall survival and progression-free survival were both significantly improved with regorafenib versus placebo. The safety profile was very similar to the CORRECT trial as well, although the hand-foot skin reaction and hepatotoxicity were more common in Asian population. However, one of the early concerns with regorafenib was its toxicity profile. Many clinicians began to start patients at a lower dose without any data and ramping up the dose as tolerated. Recently, however, this concept has been tested in a phase 2 study called the REDOSE study. The REDOSE study was a randomized phase 2 study where it randomized to RMA, which is a dose escalation arm, which starts at 80 milligrams per day at week 1 and goes up to 160 as tolerated. And the standard arm was arm B, which starts at 160 milligrams. The primary endpoint of the study was that number of patients completing 2 cycles at 8 weeks and intend to start cycle 3. And in the results, final results, where it was presented at GI ASCO, it met its primary endpoint. Not only that, there was a trend for improvement over survival in arm A compared to arm B. Now, if you look at the NCCN guideline, the dose escalation of regorafenib is now recommended. We have been doing something similar to this in my practice for some time now. So it's nice to see that this is validated in a clinical trial without compromising the efficacy. Now, Karen, what has been your experience at your institution?
I completely agree, Dr. Kim. Before the REDOSE trial, many practitioners would start regorafenib at a lower dose and escalate, or vice versa, start at full dose and have a low threshold for a dose modification, pending on the patient phenotype. This is in an effort to improve their overall tolerance and adherence by reducing side effects. The REDOSE data supports a ramping up approach.
I'd like to take a minute to discuss how we choose between these agents for our patient. So in our selections, depending on patient's phenotype, we would choose between TAS-102 or regorafenib. For example, if the patient had a lot of heme toxicity with prior chemotherapy, I would tend to choose regorafenib because the regorafenib has less heme toxicity. Or if the patient got benefit from long-term benefit from anti-VEGF drugs, I would tend to continue with regorafenib. However, on the other hand, if the patient suffered from hand-foot skin reaction or fatigue, or maybe even from diarrhea from the prior cytotoxic chemotherapy, I would likely choose TAS-102 in this setting. Karen, has your experience been very similar?
Thanks, Dr. Kim. I completely agree. When choosing which third-line oncolytic agent, you must refer to what other side effects patients have suffered from with prior lines of therapy. We absolutely take into consideration if they've suffered from a lot of myelosuppression with former FOLFOX, FOLFIRI. We will also take into account if they have high blood pressure or suffered from hand-foot syndrome. All of these factors will matter into which agent we use. For instance, patients that have suffered from myelosuppression from being heavily pretreated, we would probably lean towards utilizing Regorafenib in the third-line setting. On the flip side, if a patient has uncontrolled blood pressure, they've suffered from a lot of mucositis and hand-foot syndrome with prior treatments, we would definitely want to start with the TAS-102 in the third-line setting.
Thank you, Karen. So I think we can conclude that in terms of efficacy, we cannot say that TAS-102 is better or Regorafenib is better than TAS-102. Only thing that differentiates between the two oral oncolytics is a toxicity profile. And based on the patient's condition, we'll choose each one or the other based on the toxicity profile and what best fits the patient. For later line therapy, in addition to the two approved agents, which we have discussed, there's an interesting combination of agents which has shown some promise in an early phase 3 study. There's a combination of a MEK inhibitor called cobimetinib and an anti-PD-1 antibody, atezolizumab. A phase 3 trial is currently underway, and the results are anticipated later this year. So in summary, both TAS-102 and Regorafenib improve overall survival for patients after prior therapy. The two drugs have similar efficacy but different safety profile, and that plays a big role in selecting therapy. Stay with us to find out more about the practical issues surrounding these drugs, including dosing, patient education, and managing side effects. Welcome back. In the last segment, we reviewed the evidence on approved third-line therapies. In this segment, my colleague Karen Martin will describe some practical concerns with dosing and dose modification of these agents, managing the associated side effects, and importantly, strategies for patient education. With that, I'll turn it over to you, Karen.
Thank you, Dr. Kim. I'd like to begin with a recap of the patient case that we've been following. We have a 66-year-old gentleman who is unresectable, metastatic at diagnosis with colorectal cancer. He has molecular markers that reflect RAS and RAF wild type and microsatellite stable and has received 2 prior therapies. Initially, he received FOLFOX plus bevacizumab, and upon progression, he was given FOLFIRI cetuximab given his RAS wild type status. He's now progressed, and we are in the third-line setting. We're preparing to give him TAS-102. I'll begin with an overview of the dosing of TAS-102. As you can see in this slide, the dosing with TAS-102 is a little bit different than some of the oncolytics that we're used to. You can see that patients are giving oral tablets in the morning and the evening within 1 hour after a meal on days 1 through 5 and 8 through 12 on a 28-day cycle. When you first talk to patients about this, it can be quite overwhelming. For me, I like to think about things like Monday through Friday. So I often will try and start patients on their dosing on a Monday. So they'll take their first pill in the morning on Monday. They'll continue that sequence throughout until Friday afternoon, and then they'll have the weekend off, and then they'll do it again the following Monday for 5 days, followed by 2 weeks off. This is very important for the patients to know. Dosing is also based by height and body weight, like most oncolytic agents we use. The most common side effect of TAS-102 is myelosuppression. In some cases, this can be severe. Monitoring guidelines have been established. You must check a CBC prior to the start of therapy and at least on day 15 of each treatment cycle. These are the recommendations that we follow at our institution. Additional side effects are gastrointestinal, which include typical chemo-related side effects such as nausea, diarrhea, fatigue. These are also common in most of the oncolytic agents we use. Patients may also have an increased number of infections. It's important to review signs and symptoms of infections with patients so that they can know when to call. Dose reductions can be used to manage side effects. There are guidelines established. A maximum of 3 dose reductions is permitted to a dose of 20 milligrams per meter squared a day. Once a dose reduction has been made, you remain at that same dose. You're not to re-escalate the drug. If an adverse event is present at the start of a cycle, delay the start of treatment. If an adverse event is present During the cycle, withhold treatment. For grade 3 or 4 non-hemolytic adverse events, delay or hold treatment. And this holds true for all oncolytic agents we utilize in oncology. Resume therapy at a 5 milligram per meter squared dose lower than the previous. There are specific guidelines available for hematologic side effects shown here in the slide. Grade 3 or greater neutropenia is associated with longer survival, and a retrospective analysis found that grade 3 or greater neutropenia is a predictive factor for progression-free survival. Delays in treatment were also associated with improved overall survival. TAS-102 is safe and effective in the elderly patients, although they do have a higher incidence of grade 3 or 4 neutropenia and thrombocytopenia, as well as grade 3 anemia. In an expanded access trial, the duration of therapy was similar between younger and older patients. Older patients had increased neutropenia and diarrhea, but decreased levels of fatigue and nausea, as seen in this slide. Additional concerns may be with patients with hepatic and renal impairment. We have to keep in mind that is the third-line setting. Patients have metastatic disease in the liver, and they often have heavy tumor burden in the liver. Multiple patients can come into this therapy with high liver function tests prior to even the start of therapy. So these are indicators that we need to consider. However, in TAS-102, no dose adjustments are required with patients with mild hepatic impairment. TAS-102 should be considered cautiously with patients with a moderate to severe hepatic impairment. Patients with moderate renal impairment may require a dose reduction, and you should refer to the guidelines. Now I'm going to turn to management strategies with Regorafenib. The standard dosing for Regorafenib is 160 milligrams a day, given as 4 40 milligram tablets. Cycle is 3 weeks on and 1 week off. It should be taken at the same time each day. Regorafenib should be taken after a low-fat meal, less than 600 calories or less than 30% fat, taken with water. The most common side effects with Regorafenib are hand-foot skin reaction, fatigue, diarrhea, and hypertension. It is recommended that adverse events be monitored prior to and during the first week and every 2 weeks after that. With respect to hand-foot skin reaction, there are several prophylactic measures that can be taken. Control calluses, use a urea-based cream, provide cushioning for tender skin, consider thick socks, and avoid hot water. Preventative measures to protect pressure points such as the palms of the hands in patients using walkers should also be considered. Dose reductions of Regorafenib are in 40 milligram increments or 1 tablet. Dr. Kim, I'd like to hear about your thoughts on how you monitor your patients.
So in my clinic setting, we tend to be very proactive. Most of the side effects that you discuss with Regorafenib tends to occur early on. Therefore, depending on patient situation, I see them once a week or every 2 weeks and monitor their high blood pressure, diarrhea, GI toxicity, or a hand-foot skin reaction. And if those occur early on, I could be proactive and manage them so that they're able to finish at least 2 months of treatment so that I could do a CAT scan to see if the drug is having any efficacy on the patients.
Thank you, Dr. Kim. Both dose interruptions and dose modifications are used to manage side effects from Regorafenib therapy, and there are specific guidelines for different adverse reactions, such as hand-foot skin reaction and elevated liver function tests. There is a correlation between hand-foot skin reaction and improved overall survival. In a post hoc analysis from the CORRECT trial, you can see that patients who had suffered from hand-foot skin reaction had an improved overall survival. This is similar to the data that we saw in the RECOURSE trial with neutropenia and increased overall survival with TAS-102. Regorafenib is also safe and effective in elderly patients. In a small study, patients were given Regorafenib on a 2-week on, 1-week off schedule, so a slightly altered schedule. In this study, elderly patients were defined as 75 years or greater. The median overall survival was 8.9 months, and the median progression-free survival was 4.8 months. No dose adjustments are required for patients with renal dysfunction or mild hepatic impairment, but Regorafenib is not recommended for patients with severe hepatic impairment. In my practice, I often adjust the timing of follow-up evaluations based on their known comorbidities, just like you have previously stated. If they have borderline high blood pressure, I may monitor their blood pressure more frequently. We do know that these adverse events most likely occur in the early start of therapy or in the first 1 to 2 months. It's important that we educate our patients on this as well so that they can be proactive and know when to call us. Prevention of side effects is key to adherence. I will often tell my patients to not continue to blindly take the drug if they are concerned about a side effect they are having, and to hold a dose and to call the office with concerns. We now know that both TAS-102 and Regorafenib are oral agents, and adherence to oral agents can be difficult for some patients. In a retrospective analysis of 3,000 patients, it compared adherence to TAS-102 and Regorafenib. This study found that at 3 months, patients receiving TAS-102 had a higher medication possession ratio and a higher proportion of days covered than those receiving Regorafenib. Patients receiving TAS-102 were also significantly less likely to discontinue treatment at 60 days. At our institution, we have an adherence patient education tool that I think is phenomenal. A nurse navigator will sit down and meet with the patients prior to the start of an oral oncolytic. She reviews the chemotherapy side effects, drug itself, dosing, schedule. She also reviews the plan for delivery, as most of these agents come from a specialty pharmacy. There's also a cross-check analysis done with other medications. Once this form has been completed, it's signed by the patient, and a patient is given a copy, and as well, there's a copy put in the chart. I think it's a great tool for adherence. Quality of life is a very important concern for our patients, especially in the third-line setting. At this point, many patients have been suffering from both disease and treatment-related fatigue. Both oral agents can be given to patients with minimal impact on their quality of life. If patients are monitored for side effect, and those side effects are quickly and effectively managed. In the RECOURSE study, TAS-102 significantly delayed time to a decreased performance status. A formal quality of life analysis was not part of this study, but an analysis of adverse events known to impact quality of life, such as nausea, vomiting, diarrhea, and fatigue, supported a minimal impact on quality of life. Adverse events were more frequent with TAS-102, but did not result in increased treatment discontinuation. Duration of therapy for patients with these adverse events was longer than the total RECOURSE population. 67% of patients receiving TAS-102 maintained their ECOG performance status versus 63% of patients receiving placebo. Quality of life was measured in the CORRECT study using 2 questionnaires. Both instruments reported similar quality of life scores for both the Regorafenib and the placebo arms of the trial, suggesting that Regorafenib treatment did not diminish the quality of life. In summary, 2 approved options exist for patients in the third-line setting of metastatic colorectal cancer: TAS-102 and Regorafenib. TAS-102 side effects are predominantly hematologic toxicities, while key side effects with Regorafenib are hand-foot skin reaction, hypertension, fatigue, and liver dysfunction. Both drugs may require dose modifications to manage side effects. TAS-102 has a lower discontinuation rate due to the side effects than compared to Regorafenib.
Thank you, Karen, for that informative session. In conclusion, as Karen and I have discussed, metastatic colorectal cancer is a disease where there are many treatment options along the continuum of the disease. For later lines of therapy, TAS-102 and Regorafenib are safe, effective therapies which have demonstrated improved outcomes for patients. Effective use of these agents include monitoring for side effects and managing them by implementing appropriate dose modifications. Patient education plays an important role in quality of life, patient adherence to therapy, and recognizing side effects. Finally, a multidisciplinary team approach is the best way to manage patients with a complex disease. Karen, I really enjoyed your discussion today.
Thank you, Dr. Kim. I've enjoyed it as well.
And thank you for joining us. Don't forget to share this education with your colleagues by selecting Share This Presentation from the menu at the upper left. Have a good day.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/XWQ. This activity is supported by an educational grant from Taiho Oncology Incorporated.